And I want to quote Dr. Batts in saying that healing occurs in community. I'm Julie Thomasis. I'm a board member of Promise Neighborhoods Lehigh Valley and an advocate of marginalized communities in the Lehigh Valley. I want to extend a radical welcome to the interns, the professors, the presenters, and the Allentown community to PNLV's Health Equity Fellowship. First, I want to thank the Dorothy Ryder Pool Healthcare Trust and the Ryder Pool Foundation for their support of this program and their ongoing contribution over many years to health equity across our community. The PNLV Health Equity Fellowship is centered in the idea that wellness is a basic human right and that everyone is worthy of a fair and just opportunity to be as healthy as possible. We recognize that locally there are significant obstacles to optimum health, such as racism, power imbalances, and poverty. These oppressive factors, as well as inequities across the social determinants of health, substantially and disparately impact the health and life outcomes of marginalized and vulnerable communities. This is the second of 8 exciting informative webinars. Each webinar will have 2 presenters and cover key social determinants of health. The webinars will last for about an hour and a half. The presentations will be followed, well, actually, yes, an hour and a half. The presentations will be followed by 30 minutes of Q&A, and the webinars will be recorded and available for you to review. Our presenters are both experts in their field and leaders and representatives of our community, and they're going to share with you the inequities, the challenges, and the opportunities in our health system. You'll be assigned some pre-work to do before each webinar. My reminder to you today, as on every Monday, at every Monday webinar, is that knowledge is power. Our second webinar topic will be social determinants of health, health equity, and our presenters are Dr. Sirry Alang and Mishawn Roberts. I'd also like to introduce Ola Onawale, who is the Health Equity Project Director. She's our webinar manager / moderator and will be facilitating the Q&A. Oh, you want to go ahead, Ola?
No, thank you, Julie. Thank you. So before you came on, I actually spoke a lot about how things would be run today. So without further ado, I want to give way for our presenters.
Do you want me to do the bios?
Yes. Mm-hmm.
Okay, thank you. Okay, I want to start with Mishawn Roberts. Mishawn is currently a community center coordinator at the Charities at the Chew Street Community Center in Allentown. She attended Northampton Community College and Liberty University studying psychology. During the past 3 years, she has developed after-school programs, community events, workshops, marketing materials, and is recently running a summer food program. Through compassion and understanding, she has built relationships and gained trust among those in the surrounding community. Mishawn continues to strive towards breaking barriers, all while building unity and providing a space of peace. In her spare time, she researches and creates new perspectives for the community through healing and various techniques through self-mastery. Seeing people reclaim and step into their power is what drives Mishawn to continue her life's work. Thank you for being here, Mishawn. And now I want to introduce Sirry Alang, PhD. She is an associate professor of sociology and health, medicine and society at Lehigh University. Her research explores the role of social structures and institutions in creating health inequities. Research has appeared in journals such as Social Science and Medicine, American Journal of Public Health, Journal of Health and Social Behavior, Health Services Research. She is also in the USA Today. Dr. Alang earned a PhD in Health Services Research, Policy and Administration at the University of Minnesota School of Public Health. She got an MA in Sociology from Lehigh University and a Bachelor of Science in Sociology and Anthropology at the University of, what's that for me? Buea in Cameroon. Buea in Cameroon. Thank you so much for being here. Welcome. Okay.
All right. Okay, so thank you everyone for being here. Thank you, Mishawn. Mishawn and I talked about doing introductions so that we know who's on. Is that possible for us to quickly do that? Ola?
Yes, it is possible for you to do that. I guess the easiest way to do it is probably in the chat. I did make you co-host, so you can ask people to unmute themselves if you'd like.
Okay. Okay, so I'm gonna just call people's names as they appear on my screen, and then if I call your name, you can unmute and just say something about you and like where you're at in terms of like health disparities, health equity work. Charlene.
Hello, I'm Charlene. I am a junior nursing major at Moravian College. I am also a public health minor. So I've taken a couple classes on social determinants and health disparities and things like that. So I've seen a lot of that kind of work being done, and I'm hoping to utilize a lot of the knowledge that I learned in my own healthcare practices.
Awesome. Chelsea.
Hi, my name is Chelsea. I'm a senior nursing student at DeSales University. I live in Allentown, so I've done a lot of volunteer work in Allentown, and I'm really excited to get involved in the community more, especially during COVID.
Emmeline, today is your birthday, we've been told.
My name is Emmeline. I'm also a senior at DeSales for nursing, and I also live in Allentown, so this is, I feel like, my first big chance to really get involved in the community, so I'm looking forward to that.
Awesome. Mary Ellen? I think Mary Ellen is. Daniel Phillips?
Yeah, I'm Dan. I'm going into my second year Master's of Social Work at Marywood University, and I guess I worked 2 years as an intensive case manager and intake worker in the Lehigh County, Northampton County area. So I've gotten to see a lot of different parts of the community. So, yeah.
Thank you. Abigail.
Hi, I'm Abby. I'm a second year med student at Temple, and I'm in the St. Luke's program. I studied social determinants of health in undergrad, so I kind of have like a little bit of background knowledge, and we talk about it in a lot of my classes, but I'm excited to actually get out and do some work involving it.
Thank you. Mark?
Hi, everybody. My name is Mark. I'm an attorney, a local attorney who has a great interest in what's going on in the community and thinking about social determinants of health and how they adversely impact communities that shouldn't be adversely impacted. So hoping to find a way to be supportive in changing that.
Thank you. No?
Hi, my name is Noelle, and I'm going to be a senior at DeSales, and I'll be going into the grad program for the physician assistant program there. And I'm excited to learn more about the social determinants of health to help me be a better healthcare provider in the future.
Nikki?
Hi, I work for St. Luke's Hospital, and I am the Assistant Director of Behavioral Science and Residency Development, and I teach family medicine residents. I'm faculty, so certainly the areas I'm teaching them about are social determinants and the impact on health and health equity. So thank you.
Thank you. Ellen?
Hi, this is Ellen Denisard. I also work at St. Luke's. I'm a Community Health Liaison Manager for the Sacred Heart and Allentown campuses. I also have been sitting on the steering committee for the Zero Youth Violence program, and also working with Paz and Hassan on some other initiatives. And Dr. Reed, Rajika Reed, is on the line too. She just wanted to let me know because she's on her phone, so I don't know if she can be unmuted, but she's also listening in. So thank you.
Okay, thank you. Midalia, I'm sorry if I'm saying your name wrongly. Okay, oh, there you are.
Hi. Hello, my name is Midalia Ricardo. I'm a pre-medical student at the University of South Florida, majoring in biomedical sciences and minoring in public health. And I want to be involved in this program because I believe it will be a great opportunity to learn about the social determinants of health and apply it to my education in medical school, and also as my future career as a doctor.
All right, awesome, thank you. Charlene?
Hi everyone, my name is Charlene. I'm a part of the Pre-Health Scholars Program through USF, and I haven't really got much exposure to the community, so I hope like this experience will really expose me more out there.
Awesome. Fatima?
Hi everyone, my name is Fatima Wakil, and I'm an associate professor at the College of Health at Lehigh University. And I'm really happy to see all of you from USF because that's my alma mater. I got my undergraduate degree and my master's of public health at USF. And I'm actually in Orlando, Florida right now, so I'm pretty close by to Tampa. Anyway, so I actually moved to Allentown in December. So I really wanted to kind of get to know the community in terms of all of your great work. And I've been doing health disparities research for a long time. And my field is in maternal and child health. So looking forward to getting to know all of you.
Thank you. Mariska?
Hi everybody, I'm Mariska Van Alst. I work with Congresswoman Susan Wild in her Allentown district office. She is very interested in health disparities, and one of her primary focuses in DC is on affordable health care and making sure everybody can have access to and are able to access good affordable health care. You know, it's not my typical focus area, so I'm here to learn, and we do a lot of work with a lot of the agencies that many of the people on the call serve. So just here to learn. Thanks.
Thank you. Dr. Hassan Batz. Oh, that's actually Ola, sorry. Hada?
Everyone, my name is Hadar. I recently graduated from Muhlenberg College with a degree in public health. I'm from the Allentown area, so I'm local, and I'm interested in bridging the gap between primary care services and everything else that affects the social determinants of health, so all the other community resources that are out there. And I, too, am here to learn today.
Thank you. Nyambura?
Yes, Nyambura Mboga Daisley. I'm also a resident of the Allentown area, and I've been working in the community for the last 3 years, specifically with the refugee communities, and I'm very interested in social determinants of health. I'm involved a little bit with the St. Luke's Sacred Heart action committees, looking at different social determinants of health, and I'm also here to learn, looking forward to it.
Thank you. Jennifer?
Hi, my name is Jen Nicolosi. I am the manager of the AmeriCorps Vista project with United Way of the Greater Lehigh Valley. I am very excited to be participating today to learn about the different health disparities we have in our community and how we can close that gap, and also how we can get our AmeriCorps Vistas more involved with the work in our community to help close that gap as well.
All right, thank you. Carmen?
Hi, everyone. Carmen Bell from United Way of the Greater Lehigh Valley. I'm the Director of Healthy Aging. Sirry, Alang, and I have talked in the past about social isolation and the impact on older adults. We're trying to create an age-friendly Lehigh Valley and just recognizing programs and initiatives that support our aging community and support a good quality of life for all of the residents. So health disparities, racial injustice, social injustice are all part of that conversation. So I'm just here to learn as much as I can.
Awesome, thank you. Somebody on the phone, your last 4 digits, 0886.
Hi, this is Raj from Community Health and Preventive Medicine. This is Rajika Reed. I work as the Senior Network Director of Epidemiology and Strategy at St. Luke's. We conduct needs assessments and implement programs in the community. Our focuses are more vulnerable populations. We also conduct a health equity internship as I adjunct teach and teach public health out of health medicine and society. I also teach at Temple University School of Medicine in Bethlehem. Thanks.
Thank you, Raj. And then last 4 digits, 9514.
This is me, Hassan. Hello, everyone. I'm excited to be here and to hear the phenomenal work of Dr. Alang and Mishawn. I'm the Executive Director of the Promised Neighborhoods of the Lehigh Valley. I'm a research fellow at Lehigh University, and I'm a Robert Wood Johnson Culture of Health leader.
Thank you, Hassan. Is there anyone else who hasn't introduced themselves? We just want to acknowledge everyone in the room.
Siri, it's Mary Ellen Miller. I don't know if you called me and I just didn't hear it.
Okay.
Go ahead. That's fine. I direct the interns from the Bridging the Gaps Lehigh Valley affiliate, and this is their 13th summer, believe it or not. I can't believe it's been that long. I've worked with Hassan for about 10 years and met you a year and a half ago when you were our keynote speaker for our 10th anniversary. So I'm well aware of your work. It's really wonderful to see you again. I guess my whole focus with social determinants is to make sure every summer the interns get a better understanding by the end of the internship than they had at the very beginning, and that I can draw on my own experiences from my nursing profession and also my personal life, because I've had my own personal experiences with social determinants, as everyone has. So I just thank you for this opportunity.
Thank you. So thank you everyone for coming here. We really have a range of people, which is fantastic, from students to professors and to practitioners. And I'm really excited. I'm really excited about that. So I'm sharing my screen on this. We are talking about the social determinants of health. I just want to say before going into the content that every single one of us in this room is an expert. You live in a society. You have health. You have a health status. So you are an expert in how your own social conditions and in how your own social circumstances and your own social environment affects your health. So we really want it to be a conversation. We will talk about some of the basic things in general that we want people to think about, but we want it more to be a conversation to think about how we can improve the social factors that then lead to a range of health outcomes. So a lot of you have been doing this work and you know that. A lot of you have been doing this work, but you don't know that you're doing this work. And I think all of you just being here today, that I want to recognize and acknowledge that I know that you are an expert of your own experiences, and that you bring your expertise of your experience and just your presence here. And so when we get to the conversations and the questions and answers, please don't hold back. Mishawn and I don't have all of the answers. Nobody here has all of the answers. There's never a point where we think we've arrived and we understand health equity, or that we've gotten to health equity. We learn and we have these conversations to continue to improve the health of our communities. So social determinants of health in general are literally everything around us that affects our health. It includes access to care, it includes gender, it includes culture, it includes, our resources, whether they are financial resources, whether they are social resources, cultural resources. It also includes who controls those resources, jobs, racism, colonialism, white supremacy, languages, right? Those are all social determinants of health. Our school systems from K through 12, higher education, housing, all of those things, land, are social determinants of health. And social determinants of health are really just the conditions under which people live and work and grow and age and die. And so everything that has to affect your health, like your health status, or that can affect your health indirectly, like the access that you have to healthcare, for example, or the resources that matter or that help you get healthcare. Those are all social determinants of health. In 2010, the county health rankings, which is funded by the Robert Wood Johnson Foundation, said that social determinants of health or social conditions affect over 80% of health. And so maybe about 10-20% of our health depends on our interactions with our clinicians or our healthcare providers. So if you're a nurse, for example, or you're in PA school, or you're a physician or a medical doctor or a physical therapist, if you provide any clinical care, a lot of health happens way before you walk into the medical room to have that first encounter with your patient. So everything that happens outside of the clinical room is a social determinant of health. That's separate from the healthcare system, but that's really related to the healthcare system. So in thinking about the social determinants of health, the story that we all talk about, the visual that we all talk about, is that healthcare and medicine focuses on getting people out of the stream, pulling people out of the stream and they are drowning. And addressing the social determinants of health is going upstream to figure out what is pushing people in that stream to begin with. We can't just keep pulling people out when they are drowning. We have to go upstream to figure out what is pushing people in the stream. And so social determinants of health are those factors that affect people's health way before they ever step into the exam room with their clinicians. Social conditions in general, and in thinking about the social factors that affect health, a public health scholar and a sociologist came together to propose what we call a fundamental cause theory, which really just means that social factors or social conditions are the fundamental causes of disease and health, that they are by far the most important predictors of health. So your health really depends way more on the social conditions in which you live, in which you work, in which you grow up, than your actual access to care or your interaction with a clinician. And there were four reasons why social factors are fundamental causes of health and of illness. And the first one is that social factors influence multiple disease outcomes. So you cannot take one social factor, for example, the environment. You cannot link a person's physical environment just to one health outcome or just to one disease. So you cannot just link the environment to asthma. You can link the environment to diabetes. We can link the environment to COVID-19. We can link the environment to heart disease. So social conditions affect multiple disease outcomes. So that's why they are a fundamental cause. Social conditions are also tied to multiple risk factors for sickness and for death. So social conditions affect a host of different risk factors. Social conditions not only increase your blood pressure, but they affect your immune system. Social conditions may not just affect your immune system, they might actually cause anxiety and depression that then increase risk factors for other physical health conditions. So social conditions might affect whether or not you have health insurance, whether or not you have access to a doctor, whether or not the doctor in your community provides care that is culturally or structurally competent. Okay, so social factors are tied to a lot of risk factors for different disease outcomes. And then the third element of a fundamental cause is that the disparities that we see in socioeconomic resources, that they match and are evident with disparities that we see in health outcomes. So for every disease, people who are of higher socioeconomic status, so people with higher education, people with higher income, for example, people who live in communities that are resource rich, that for every disease or for every health outcome, they do better compared to people with lower education, people who live in communities that are less resourceful. So there's this, the socioeconomic ladder recreates the healthcare ladder, or recreates the ladder in terms of access to care. And then the last thing is that new factors often strengthen the association between socioeconomic status and health. So a simple example to explain this is think about diseases that were linked to poor sanitation, right? So think about cholera, for example, typhoid, diseases that were connected to poor sanitation. We have, as a community, significantly addressed, we've not eliminated issues around poor sanitation yet, but we've addressed significantly issues around poor sanitation. But there are still new ways in which socioeconomic factors shape health. It's no longer poor sanitation, it's access to healthcare. It's no longer poor sanitation, it's mass incarceration. It's no longer poor sanitation, it's resource poor school districts. It's no longer poor sanitation, it's police brutality. It's no longer poor sanitation, it's our horrible, oppressive, and violent immigration policies. So the social factors that, you know, strengthen the connections between socioeconomic status and health, that new replacing mechanisms tie poverty, tie social conditions to health outcomes, right? So it may not be the fact that we don't have vaccines anymore. It could just be the fact it could be housing discrimination, for example. So there are new ways in which inequality shapes health outcomes, new ways in which white supremacy shapes health outcomes. And so social factors are fundamental causes of health because of these four features. They don't just affect your chance of having one disease. They would increase your chance of having so many diseases. They'll increase your chance of dying from a disease once you have it. They'll increase your chance of being treated poorly by the doctor once you're poor and you step into a hospital. Okay, so it affects multiple disease outcomes, and it's, you know, it's tied to multiple risk factors. And for any health outcome, again, if a person's socioeconomic, we can predict a person's whether they would live or die if they have a disease, or whether or not they will have a disease. We can reliably predict some of their chances of having that disease because of their socioeconomic status. And then I want to quickly talk about the difference between health disparities and health inequities. We use them interchangeably, but they are not. A lot of people prefer to talk about health disparities when what they should be talking about is health inequities. So health disparities are simply differences in who gets a disease and who dies from a disease, or just the burden of diseases or adverse health outcomes. So an adverse health outcome that is not a disease could be insurance status. So disparities in the number of people who have insurance in one community compared to another community. There are different kinds of health disparities. There are gender health disparities, age health disparities. A good example, and then a health equity or health inequity are those differences or disparities that are unjust, that are unfair, and very importantly, are avoidable. We can do something about them. So that's an inequity because it's unfair, it's unjust, It's grounded in the unequal distribution of resources. So an example that could help us distinguish health disparity from health inequity would be disparities, gender disparities in breast cancer. So women are more likely to have breast cancer. That's a disparity. It's not unfair, it's not unjust, right? It's just because women have more mammary glands than men. Men do have breast cancer, but the rates of breast cancer among men are significantly lower for obvious biological reasons. Those are not unfair or unjust reasons. But then among women, women of color, Black women, indigenous women, and Latina women are more likely to die once they have breast cancer. So that's now an inequity in breast cancer mortality, because something can be done about it. It's because of access to resources. It's because of environmental conditions. So a lot of the times, there are really, really few health disparities. There are so few things that we can think of as health disparities. Age disparities in dementia, for example, that's a disparity, because the older you get, the more likely it is that you have dementia. That's a disparity, but there are only really few circumstances. A lot of the health disparities we talk about, the health disparities in COVID-19, it's not a disparity, it's an inequity. It's unjust, it's unfair, it's avoidable, it's grounded in our unequal distribution of social resources, or of resources that matter for health. So the disparities are often inequities, not always, but they are often inequities, because people who experience these disparities are often the same groups of people that experience inequality. They are often the same groups of people who are marginalized and excluded and oppressed. They are the same groups of people who have unfair access to resources, and our society is structured in a way that reproduces health inequity. So it's really important to say inequities when we mean inequities, not disparities, because disparities, it actually carries the connotation of like, oh, it's these health disparities, what are we going to do about it? But inequities means that they are unjust and are unfair, and as a society, we have a responsibility to change them. I would hand over this part of the presentation to Mishawn.
Hey, Dr. Alang, if you have some more things that you want to add, Mishawn is having some technical difficulties. She just emailed me, so she needs a few moments to get back on. Sorry.
Okay. So I think I'm going to let her slides be when she comes back on. But some of the things that I didn't talk about that I'd like to talk about around disparities versus inequities is the idea of where do inequities come from? Is it possible for us all to achieve health equity? And the answer is that it is possible, but that possibility only comes when because everybody experience we also talk about communities that experience inequities. In general, when we refer to communities that are marginalized or that are oppressed. But communities that also benefit from health inequities experience that equity. So they reap the benefit. Marginalized communities only experience health inequities because advantaged communities reap the benefits from inequities. There's no, let's just treat everybody equally and we would all be fine. It's that the poor health outcomes in communities that are marginalized come at the expense at the benefit of communities that are not marginalized. So communities that are marginalized, communities that are not marginalized, it's not just, sort of out of chance. I'm not marginalized and I want to do everything to make sure that everybody benefits. It's that I'm not marginalized, but the fact that I'm not marginalized is clearly a result of someone else being marginalized. And for us to be able to achieve equity, that communities that have these resources and advantages and privileges should be able to relinquish those privileges. They should be able to redistribute power and redistribute access to resources for us to achieve equity. Mishawn, are you ready to go?
It's showing for me that she is still joining. Let's just give her a second.
Okay. I think about health. I think about health disparities as unconscious bias. Because when people talk about unconscious bias, they often talk about it as something that they can't do anything about it. It's unconscious. I didn't know. And that's how I think about health disparities. And I think about health inequities sort of as more white supremacy, like something that oppresses, something that someone has to take responsibility for, and something that we can actually do something about. And I think that the way we talk about inequities and disparities really matter, because they would force us to see where we can find opportunities for intervention and opportunities to make differences. I often say, when students say health disparities in lung cancer, and I always say, like, do you mean inequities in lung cancer? Because it's not random. It's unjust, it's unfair. We can do something about it. Technology is always something.
I know, I appreciate everybody's patience. This has been a difficult webinar for us all to navigate, but this must be really important information. I feel like when things happen like this, it's because it's really powerful things that need to be said. So you just have to push through it, right? Okay, let me see. All right, let me try one more time reaching out to Mishawn and see if I can help her troubleshoot.
It says she was on. She left.
And Mishawn, are you on?
I'm hoping that this is working now. I apologize. My systems were giving me some issues. I'm having like 2 laptops up trying to work this out in a cell phone.
Hi, Mishawn.
Hi, how are you? Thank you guys for being patient with me. I appreciate it, and I apologize. But yeah, so I wanted to start off with speaking about the environment that we live in. Is it my turn yet? Hopefully you guys weren't waiting for me too long.
It's all good. Go ahead. Yeah.
Okay. Just pray everything works out for me in the technology world. So the reason why I have this photo here, we have one side that's very cluttered and then one side that's very clean. So when it comes down to environment and the community, it plays a major part in the brain's developmental when it comes to processing information and actually having proper brain function. So if you guys take a look at the first room, right, the first room is full of different things. It's cluttered. I think in my mind, it creates a bunch of disorganization, anxiety. It doesn't allow me to be able to really focus and be in tuned to things that will allow me to develop in a healthy way. And if you take a look at the second room, it's very clean, it's very clear. It's very inviting for you to actually be at peace and be relaxed. And if you think about it, which room would you rather be in? The one that creates constant stress, or the one that provides a space of peace where you can actually navigate and do things? So when it comes to a environmental space, it's actually a space in which a living organism dwells and is influenced. So if you're coming from a space of chaos and you're living in a space of constant chaos, that then interrupts logical thinking, because you're constantly using a space of your brain where it is producing a disruption due to the normalcy of chaos. So when people are in a constant space of chaos, it becomes a normalcy to them. So anything that is not chaotic is then viewed as different. So peace is viewed differently than chaos when you're living in an environment where there is a large amount of crime, where there are drugs, where people have history of not managing mental illness or health issues properly. Your environment depends solely on what the visual is and what you are being influenced in that environment. So when you have a space and you're in the inner city, outside it's different. So it's not as clean. Unfortunately, it's just kind of like, lost my nose, that kind of threw me off. So it's kind of like, I'm from Baltimore City. I work in Allentown, but I live in Bethlehem, and the environment in Bethlehem is different than the environment in Allentown. The space in which I dwell in is a lot more appealing visually. In Allentown, there is a lot of, I don't want to say the word trash, but it's a lot of trash on the ground. And that in itself influences people in a negative way, where it doesn't provide a positive space for people to mentally be able to process certain things. So in order to kind of get a better understanding of how being in a collective community can influence someone, you have to kind of start off with the history. How did it become this way? So I'm going to relate a lot of this back to the Black community, because that's where I'm from, and this is me talking about community and my experiences. So going back in history, 1930s, there was something called Black Wall Street, and it was up in the rise where people were having their own businesses. You know, we were separated. Of course, there's segregation, but we were separated. So we had our spaces where we were creating certain things for our communities. We had our own doctors, we had our own hospitals, we had our own dentists, you know, business people had their own businesses, and we were well. Unfortunately, some people didn't like the development of I guess you could say the influx of African-American businesses. And then what they did, they started to do something called redlining. And redlining is actually taking a line and drawing it throughout different portions in the community and lowering the rent so much that someone can come in who was non-African American come in and purchase that land. And from purchasing that land, they then increase the property values so Black people couldn't rebuy back their property. After that, since we're going into social economics, all of these things are intertwined. So because of that, the creation of public housing was then implemented. So the creation of public housing disrupted the family in regards to, you know, having a Black male in the household. That's one of the things that it disrupted. So, and I'll tell you how. When you're having public housing, it was offered to low-income families in which property was being taken. There was only a few sources of income, or the income was no longer what it was because of redlining. So the creation of public housing, the stipulations were there can't be a certain amount of people who live in your household, or there can't be more than one income. So what that did was provide the family with supplemental income like food stamps, cheaper housing. If you have more kids, you get more food stamps. So they were encouraging the development of relying on a invisible system that posed in the form of help, but the help wasn't necessary help, it was created help. And so you have a mentality over years and years and years that is played on the community, which all plays in the part in the grand scheme of things, and how the environment and the social economics of that community have been disrupted due to imaginary help that was given. And then we're here at education, employment, public housing, and welfare and family. So education and employment, I would say, goes hand in hand. My mother, she was a teacher in Baltimore City schools for about 40 years. I spoke to her about this prior to doing this presentation, and she told me the amount of resources that were lacking in those school systems were phenomenal. I'm sorry, not phenomenal, but I mean, it was a large gap that was missing in regards to allowing people to have certain resources to even teach their classes. So she saw that there wasn't any materials for art classes, any materials for music classes, and the quality of education people are receiving in those inner city schools are completely different from the quality that they would be receiving in a different community setup, right? So if you're not having proper education, then you know, even if you do go to college, you may most likely be behind, and you're not necessarily getting a fair chance at being able to be what you would like to be. So because there were drugs introduced into the community, most people in those communities see that drug dealers are, I guess you could say, the heroes of the community, because they get money, and they get money fast. And because of that, people are more likely to go the easier way rather than finding a way to get something more meaningful, because it's unavailable. Employment is low. There's not enough money to be made in working wages. Even if you are receiving public housing, you're most likely in a one-family home, and one-parent homes. And most one-parent homes either have one income, or there's two sources of income, but that would also require some sort of government intercedence in that space. So it's kind of like people are in a rock and a hard place. They are trying to find some sort of salvation for themselves, but because of the mindset needs to be changed in order for things to move forward. But like I said, it took a while for us to get to this specific point, and now people know this as normalcy. So with that being said, the family, I guess you could say, and I don't say guess, but when it comes to family, right? Because of public housing, welfare, and the family system, a lot of the mental illnesses, I wouldn't say mental illnesses, but a lot of the mentality that was interrupted in regards to the development of people's minds, because it's like you're in a flight or fight space. You're working to stay afloat and working in a chaotic mode at all times. So you're not necessarily using your brain in its all functionality. You're using the reptilian space of your brain, which works solely on fight or flight, and you're constantly burning your adrenaline. So it's not like you necessarily have the space to up and go and figure things out in the most proper way. So you become reliant on the system to help you. And that also interrupts your family dynamic, because if there's only a one parent income home, the kids aren't able to have that sort of support for themselves, because you're working and you're trying to stay afloat. And by the end of the day, after 2 jobs, you're tired and you're not able to interact with those kids. And then your kids will then be influenced by other outside modalities. So that's something to keep in mind with that. And let's move on to access of healthcare. So a lot of spaces, a lot of spaces, I would say, in the Black community, we haven't healed in regards to just our mental space and our mental being, because sometimes you wouldn't know what to heal if you don't think there's anything wrong, right? So people looking, there are people who look forward to having these benefits instead of seeing another way out. Some people aren't able to see another way out because this is all that they've known. So when it comes to health access, some people only know what they know. And it doesn't mean that, that they are not good people. It doesn't mean that they are not smart. It's just they only know what they know. So when it comes to health access, I don't believe everyone is getting the care that they honestly deserve, because they may not be asking the right questions. So I don't feel like people are being properly educated, and the access to health is insufficient, and the quality is also insufficient in these spaces. Also, a lot of people don't have cars, and there's a bus system. And so when it comes to a bus system in Allentown, I think it's an hour for every bus. And I know in Baltimore City it's about 15 minutes for every bus. But some spaces don't even, you can't get a bus to certain spaces. Not everyone has money for an Uber or a Lyft. So to even get to these places that may be far out to actually have quality care, I don't think that's necessarily fair. So, I could get to St. Luke's, I can get to 17th and Chew, I can get to Cedar Crest, and I can reach all those spaces on a bus pretty fine. But if I wanted to go outside of that to get better quality of care, I may or may not be able to, depending on if I have a car or not. That's just an example in Allentown, but I know in Baltimore City we do have Johns Hopkins Hospital, which is a really great hospital. Most people have access to that space, but I know in other spaces, in smaller towns, I would say maybe in Alabama, everything's very spread out and it's hard to get transportation to certain spaces. So that's one thing. And then insurance, a lot of people do have Medicaid or Medicare, and they may even have certain things, but when it comes to getting your prescriptions covered, a lot of prescription and drug companies, they increase their prices on a regular basis. So how can you afford to continue to treat your illness, if you don't have adequate insurance coverage? that's something that I see people run into quite often. I would say a lot with diabetes medicine. I remember recently my mother, she's actually a diabetic, and she mentioned that she used to pay $60 for one of her diabetic prescriptions, and now it's about $200 or $300. So that's been most recent, and I know that happens more often than not. So having adequate insurance coverage and the amount of money prescriptions cost these days, that definitely is something that we need to take care of as best as we can. And then the last one is health behaviors. You're speaking mainly about mental health again. So I kind of want to expand on that. So there was 500 years of slavery and justice, and then you have 100 years of Jim Crow, and then you have another 100 years after segregation into now, right? So that's about 700 years of unresolved healing. What happens is a lot of that negativity gets pressed down into your subconscious, and then subconsciously, when you become a parent, you're passing that down every generation. So think about many generations of people just living in a space of trying to survive, and you're passing that down. Not only that, it gets coded in your DNA. So your stress that you're passing down and your genetic, I guess you could say dispositions, those are also being passed down, every time someone is being born and not resolving any of those major health issues. When it comes to drugs and alcohol, the drugs were introduced into, once they formed public housing, drugs were introduced into those neighborhoods. They didn't just pop up out of nowhere. They were introduced by an outside entity to also continue to lower the vibration and the frequency of the people who were living in that environment. And if you think about it, over in Allentown, Bethlehem, or mainly think like I would say Bethlehem, you're not going to see liquor stores. You're going to see fine wine and spirits. So even the word choice is meaningful. If you see the word liquors, it just seems completely off-putting. But if you see fine wine and spirits, it's more inviting. But it's just those slight changes of words that can control or change the trajectory of someone's thought process. A lot of people, are coupled. They're coupled with mental illness and drug or alcohol abuse, and that further dictates, a society and how their community is also shaped. When it comes to diet and exercise, because most people in these communities, they're receiving food stamps, or they have WIC. WIC is a little bit more lenient, not lenient, but they're really strict when it comes to, you can only get this, you can only buy these things. And they're healthier items for the most part, but not fruits and vegetables. When you're getting food stamps and you have a bunch of kids, you're going to choose what is the most inexpensive and that can last you the longest. So that's pastas, that's heavier meats like pork and beef, maybe some chicken, maybe some canned fruits, some canned vegetables. That's not ideal, but if you come to Bethlehem, you have all these fresh markets every Thursday. You have farmers markets. Yeah, you have it in Allentown, but when I go, I don't see any of our people there. I see different people there. So it's available in some spaces, in some spaces it's not available. You go to, like I would say, Baltimore City, we have Lexington Market, a lot of fast food, fried foods, a lot of things of that nature, not a lot of fruits and vegetables. So the access to those healthier fruits and vegetables aren't really there. If you go to the actual grocery store, we have fruits and vegetables there. But culturally, it's not really people aren't really choosing those things. They're choosing the things based off of what they have. So the fruits and vegetables are a little more expensive than buying a can of green beans. At least you got your vegetables and at least that, but it's not the same. And a lot of those are riddled with different metals and aren't nutrient dense foods. So with that being said, you know, if we could find a way to implement more healthy foods and healthier items into our communities, that would be great. I mean, there is, you know, a few people who are, you know, turning to becoming vegetarians and vegans because we're understanding a little bit more health reasons for why we're doing it. But a lot of the fruits and vegetables that are available have a lot of GMOs. I don't believe I've ever seen anything organic in a grocery store in Baltimore City. I don't think I've seen anything organic, but a lot of things have those GMOs or they're conventional fruits and vegetables. And, you know, we know those modify your DNA to a certain extent. So to have true health, it would be nice to be able to access those things. And my last point is abortion clinics. People are encouraged to either have a bunch of kids and live and be completely indebted to a system, or you have the option of abortion. And the reason why I place this here is because I personally feel that it's more encouraged. I don't think I've seen a abortion clinic in Bethlehem. I don't know where there's one. I know of one or two in Allentown, and I know of a bunch in Baltimore City. So I'm just making a general comparison. It's kind of like there is less information and support when it comes to the family system, when it comes to safe sex and unprotected sex. So kids are increasingly having more intercourse than not these days, and then that leads to people getting pregnant and not having a safe space to really, you know, to advocate for them or to know what to really do. So then there is the abortion clinic that is there to quote unquote support people who are in a difficult situation. I wish there was a better way for people to feel more supported in those communities so they can make a better choice for them and their child. But all I know personally, a lot of people tend to go the easier route than not because of the lack of support in their household. So all I really know is that as a people, you can go to the next slide, my personal solution would be to reclaim our communities, because I feel that we've given too much responsibility for a system to care for us. I would start by cleaning up our neighborhoods, like physically cleaning up the neighborhoods, because that'll at least provide us a space of, you know, this is my space. It provides a sense of ownership. This is my space. This is the space that I've cleaned, and it provides the mentality of a free mental space to start doing the more internal healing work that has to be done. And I feel like people who have a good grasp on certain concepts would be able to go into those communities and offer some love and support to people. We can't continue to rely on the system to change. I mean, we can ask them, but I feel like if they wanted to do it, it would have already been done. I know the system isn't perfect, it doesn't have to be perfect, but in other communities, it's modeled pretty well. So if it's modeled so well in other communities, then why couldn't it be in our community as well? So if we can, you know, kind of all come together and start reclaiming our community, taking more responsibility for where we're at, and we can start moving forward and working towards our healing work. So that's more so my part.
Thank you, Mishawn. I have a couple of discussion questions, but I want to go to this slide, and then I would have the discussion questions up, and then we would open it up for questions and answers. But so this slide was in the, I took it out from the reading that, you know, I said if people had a chance, they can read. So when Mishawn talked about, we have to reclaim our community. So these are the different strategies to address the social determinants of health. And reclaiming our community falls under the middle of the individual impact. So sort of the, you know, the midstream. What can you do as an individual to address the social determinants of health? How can you address the needs of your community as an individual? It talks about if you're a clinician, if you deal with people, if you're a social worker or a community health worker or a social service provider, how can you think about the social determinants and how can you address them? And we can't address these factors without knowing them. So how do you collect information that's useful? And so part of reclaiming our community is to think about what we can do as individual members of the community. And sometimes it's tiring when we all say the system is messed up. We are the system. And we have to think about how we can hold ourselves accountable and how we can improve our communities. But I want to talk a lot about, not a lot, but significantly, and really emphasize sort of the more upstream issues. So there's community impact and improving community conditions, and then there's the tactics that depends on law, policies, regulations that create these community conditions. So the conditions that Mishawn talked about, the employment, the housing, mental health, substance use, abortion clinics, all of these things are linked to policy. And so communities that are impacted negatively by health inequities, these communities didn't make the rules. These communities didn't make the decisions that are now oppressing them. And so policymakers should be able to implement policies, to legislate policies that have positive health outcomes for communities that experience health inequities. So we've talked a lot in public health in the past 5 years to 10 years about health in all policies. So thinking about how policies around transportation can affect health. Mishawn talked about that. Thinking about how policies around employment can affect health. Thinking about how policies around housing and education can affect health. We have to hold our policymakers accountable for whatever policy, whatever legislation. What are the health outcomes of those policies and those legislations? But it's also important to go beyond health in all policy, to think about equity in all policy, to think about racial justice in all policies. Okay? So how are our policies upholding racial inequities? How are our policies upholding white supremacy? And I was talking to someone yesterday that people who make policies, the policies tend to reflect their ideas. It reflects their experiences. So how are people who are marginalized and excluded represented in the policy making process? It's really important, because if you're a policymaker, the decisions that you pass, the policies that you fight for, often reflect your own ideas and your own experiences. How have you tapped into ideas or experiences of other people? And this is not just for policymakers, but if you're a healthcare administrator, even if you're a teacher, how is your sort of your work? Whose knowledge are you sharing? Whose knowledge is like referenced and canonized and like this is where to go to? So we have to really think about policies are shaped by people, and we have to really question and be critical about whose voices are lifted up in the policy making processes, who is making that policy, who's represented, and how are they listening to voices of community. We have to go beyond, we are beyond health in all policies. We should be talking about racial justice in all policies. Because if we talk about health in all policies and we know that the healthcare system creates and reproduces inequities, it doesn't matter if we talk about health in transportation policy, because the same injustices that are in the health policy will just carry over to transportation policy. So we have to, regardless of what policy it is, how are we looking at it in a racial justice lens? How are we figuring out that that policy is not going to, number one, disproportionately impact certain communities? It's not going to, number two, benefit communities that are disproportionately white. Because there are two separate things. It can benefit white communities, but then it doesn't have any impact on communities of color. It can benefit white communities and it can oppress communities of color. And we should think about accountability in every policy. How is it centering racial justice? We've passed the point of health in all policies. We all know that our healthcare system, there are a lot of inequities in our healthcare system, and they will just transfer to other systems. So I think it's really important. And of course, there's the downstream, part of it that talks about medical interventions, talks about what you do at that point where everything has happened. So we agree, you individually don't have control over our health policy in the US. You individually don't have control over our education policy. But that moment when a person walks into your office, into your examination room, you have control over how you make that person feel, how you would make that person feel. You have control over whether or not you treat that person as an individual who has needs, who has things that they like. You know, you can't just treat them as a case. You have control over that relationship in that moment. You know, Julie talked about how healing happens in communities. One of the ways I've heard that said by Hassan is like healing happens in relationships. And in that moment, when you are with somebody, when they come to your office, when they are coming to get food, when they are coming, in that moment, you have a responsibility to center justice and equity in that moment. And that's sort of the more downstream interventions that we can do to think about how our own thoughts and our own understandings of racial justice play into the relationships that we have with individuals. And then I'm gonna go back now to, these are discussion questions that I want people to talk, but I know that we have people who will talk regardless of, like, you know, they don't need to answer the questions, but these are just things to think about in your own community. Think about, like, how can you be involved in addressing the social determinants of health and in addressing health inequities? What are some of the things that you know about, that you've seen in the community that have like sat with you and that bother you? What are your own experiences or experiences of others? And you don't have to share your experience. We already know enough. I think everybody knows enough about how bad, like, people are treated, not just in healthcare institutions, in other institutions. So I don't want you to revisit that trauma. But if you find value in talking about it or in sharing that experience in this space, I invite you to. But I also invite you to say, nope, not talking about that. But to engage with some of the ways that we've seen or we've experienced the negative impacts or even the positive impacts of social determinants of health. Like I would invite people to think about, to reflect on how they've benefited from their own social conditions that have affected their health positively, and to know that benefit. And I say this not to make people feel bad or to feel guilty, or to know that the fact that you've benefited from your own social conditions that have affected your health positively, to remember that comes at the expense of other community members. This exact same social conditions that you've benefited from, those exact same social conditions are affecting them negatively. And to be able to reflect on that. We often ask people to share their stories of marginalization and their stories of oppression, but I'm inviting people to think about their stories of privilege and of advantage, and how, you know, they have benefited at the expense of other people, to recognize that and to think about how to relinquish that in building our community. So I'll open it up for questions because I ramble a lot, so I'll stop.
Thank you so much. Thank you so much to Dr. Alang and also Mishawn. We really appreciated you guys presenting to us and talking to us very extensively about the social determinants of health, and making those really key points about each aspect of it. So now that we're opening up to Q&A, Dr. Alang, I see that there have already been 2 messages that were sent to the group. So if we could just address those two first, and then it looks like there was a third, and either you or Mishawn can address them. So it looks like the first one was from Mary Ellen.
Okay.
And Siri, I wasn't asking a question. I was just reminded of when you were talking about the 80% of health that happens and how important the determinants are for contributing factors. The thing that just came right to my mind was health communication and how verbal versus nonverbal, and the nonverbal accounts for such a high percentage. So it's just like, just a comment, not a question.
Yeah, no, it's really important. I'm glad that you brought it up. In the midst of everything that's been going on, and a lot of us, I'm sure everybody's place of work has sent out an email saying we are anti-racist, we reject racism, all of those things. That's a verbal communication. There was never a time where Lehigh University, where I worked, sent an email saying we embrace racism, so distrust us. We completely, my distrust for institutions is not because they said so, it's because of their actions. And so our non-verbal communication, our actions, our non-verbal interactions speak a lot more than the things that we say. I appreciate you bringing that up. And then Julie, you had your question about Medicare, whether or not it's when I talk about redistributing resources and people relinquishing power, if Medicare for all was one, and I completely agree. I think that everybody deserves healthcare. And Medicare for all it really is one way of saying, today I can be sick. I expect you guys to take care of me. Tomorrow, someone else will be sick and I expect to be able to take care of them. We all pay into different taxes in this country and different systems. And I think healthcare should be one of them, that it's part of the social contract. If I was driving to Bethlehem and on 22 and I had an accident, and somebody called 911, I'll expect that they would send an ambulance to come get me to the hospital. I should also expect that if I get sick, that I should be taken care of as a member of the community. But we often expect that things like that can happen. Like if there's a fire now, somebody has to show up and save me. I expect that. I should also expect that if that happens to my neighbor, they should be treated properly. And so I expect that if my neighbor has cancer, that the society needs to step up and take care of them. That's how I think about Medicare for all. Like it's a social contract. You pay into something and know that it's one day you're going to have to be sick and you're going to have to call 911 or call the fire department or whatever it is. Mishawn, what do you have thoughts, things to add on that?
Not on that one, but the next question I do when it comes to the Uber and Lyft. So I see a question here. Let me get the name. I think it's from Hadar. Yes. When she was speaking about, she asked transportation when it's to get to certain hospitals or appointments. Sometimes they do, sometimes they don't. So it just depends on your type of insurance, or if you are like a Medicaid recipient, not Medicaid, Medicare recipient. And the only reason why I know that is because I do Uber and Lyft on the side. So they will provide a ride to people based on their type of insurance coverage. But then yet again, that's depending on your type of insurance coverage. So it's not accessible to every person who may need to go to a appointment. But then again, it's a Lehigh Valley, which is a different dynamic than people who are in inner cities. I don't know if they have that access or not.
I was asking because I know that it's a service that exists, but that was just an example of a service that meets the needs of like individuals on the social needs level, on that individual level versus like the community level. Mm-hmm. The article was talking a lot about policies being the things that change social determinants of health on the community level. So I was wondering if you guys think that those services that meet the individual needs are things that are being done kind of in the meantime, or like while policies are like brewing, or because it does take a long time to get policies enacted and to get change enacted at that level. So I was just wondering what you think about that, and if you think that there's a way for the two to interact in a different way.
I mean, what I would kind of say is this. I think that is a good thing for like the short time, for short term. But what I'm thinking, just kind of in the future, how long can that be kind of withheld for people to use resources to buy a ride to get to the doctor's office? And when I'm saying reclaiming your communities, getting in touch with your neighbors, whether your neighbor might need a ride one day to get to where they have to go. It's kind of building within your community the way it is now, instead of relying on someone else to do it for us. So if you know Miss Johnson has an appointment at 2 o'clock because she always takes the Atlanta bus at 2 o'clock, why not sometimes, hey, instead of taking the Atlanta bus, maybe I can take you this afternoon, and kind of build, a relationship with Miss Johnson throughout the time. And if you can't take her every single time, there may be someone else in your neighborhood or your community that you can connect with to help her get to where she has to go. So it's, in my mind, it's kind of creating a complete independence from a third party coming in and taking it all into our own hands.
Thanks.
No problem.
Thank you all for chiming in and keeping it moving on the question and answer. I also want to acknowledge Jennifer. She posted a comment. It doesn't look like a question, but she posted a comment. I don't know, Jennifer, if you'd like to speak yourself and ask any additional questions for Dr. Alang or Mishawn. Okay, yeah, I don't think that Jennifer is chiming in, but can you all see her comment here? Dr. Alang, can you see?
Yeah.
Okay.
Yeah, I see her comment. I think in some ways I resonate with that, in that there is just there's no hope really to think about how to address this. And one of the things I said earlier is that part of it is that we are increasingly asking marginalized communities to fix a system that they did not break. I think that it's possible to address or to achieve health equity if people who've benefited from the privileges and opportunities benefited are able to relinquish those benefits and redistribute power. And there are ways of redistributing resources. Medicare for all is one of them. I'm thinking a lot of things can be the same. I mean, the internet should be a public good. There's so many things that should be public goods, and we should invest in our public schools. I think that if we do that if we address these social conditions, we can reduce and close some of these gaps in health outcomes. And then it's not going to happen overnight. I don't even see it happening in the next 10, 20, 30 years. I think it's a long road, because Mishawn said, like, we've had hundreds of years of institutional mistrust. People are not just going to start trusting the medical institutions. There should be evidence. We can't just be told, trust us, we reject racism, we stand with the Black community, trust us. Because that's not why they distrust communities, institutions to begin with. So I think it's going, a lot of the times I share that like nothing is going to happen and this is it. But I also think that we are at an inflection point. And I think that it's really possible for change. I've not in my lifetime, this is what we see now, similar to what we saw in the 60s. And of course, nothing changed, what we read about in the 60s, some of us. And of course, nothing changed. But I think we are at the same inflection point where we are seeing this mass mobilization of white allies and white accomplices. And I think those are the people that are really, they should be responsible for fixing the system. Because again, we didn't make these rules, we can't fix what we didn't break. And I share the lack of hope, but I'm also hopeful that we are at an inflection point where things can happen. And I agree with Mishawn that like communities we need to focus on rebuilding our communities and thinking about sustenance, and that's a way for us to survive. to not die. But I think we need more than just surviving. I think the entire system needs to change. And I really think that that's the responsibility of white people, people in power, people who have benefited from these resources historically.
Thank you. Thank you. So we have another question here from Mark. So Mark, I see that you're unmuted. If you want to go ahead and ask your question, I see your hand raised.
Yeah, it wasn't so much a question as it was some comments. So, you know, I'm white. I am a male. I have benefited greatly from both of those privileges. And it's all kind of exponential, right? So you're white, you get a better education as a child, which probably means you get a better education as a young person, which probably means you get a better job, which probably means you get access to better food, which probably means you get access to better housing, which probably means you get access to better healthcare. And in my experience, while white folks in this community can sort of connect with charity, especially for children, their willingness to challenge systems and structures and sort of the normal thing that's in place is just really not there for most people. So by way of example, I was on the board of the Boys and Girls Club in Allentown. And, you know, people from all kinds of different backgrounds, corporations, communities were willing to serve on the board and take care of the kids as best they could and all that kind of stuff. If you start talking to them about poverty in the neighborhood and how you can help the families and the parents of those kids, they quickly turned off and were no longer interested, because that might threaten some of their privileges and that might require changes in how we distribute income and how we value people. So to me, a lot of it's on us white folks to figure out how to persuade our white siblings that this is something that needs to change. And we can tweak around the edges and we can try to get people Uber rides or whatever, and you know, stronger neighborhoods and communities are wonderful, but until we attack some of those basic foundations of privilege and power, the fundamental dynamics aren't going to change. So I don't know. Just felt that I needed to say all that.
Yeah, well, Mark, I think that's a really solid and valid insight. I appreciate that insight too, because I feel the same way. I feel like people aren't able to challenge the system, especially when it's kind of like in their favor. So they don't really see a really need to do so, and they can't really relate to the issues of what's going on. And there's nothing completely wrong. I don't think there's nothing specifically all the way wrong with that at all, because it's just people in their own perspective. But I feel if there's enough people, regardless of race, for me, I see people making changes in the community, regardless of who they are. I feel like, you know, we make changes unified and in a group. There's people who are standing up for different causes. We don't have to take on everything all at once. It's just find something that you can do really well and find other people who do the same thing really well and then do it. You know, it's kind of like, you know, so for instance, there is a group of people who go to the HCC and hand out food every Friday, right? And they just get donations. Like, that's the only thing that they do. They're only focused on those things. And the grand scheme of things, they're changing someone's life. They're making a difference in that community. But like, what if there was like another space that they could either afford more resources, you know, for other people in different ways? So it's like we're not going to make a change overnight. Well, actually, to a certain extent, you could. So right now at the community center, you know, in the midst of COVID, we used to be a soup kitchen. We still are a soup kitchen. On the same token, you know, we had to change things and modify things because we couldn't have people in and out of our community center. So we hand out boxes once a week, every Friday. We feed about 1,500 people every Friday. So each box contains enough for a family of 5 to 6, right? So that's making a difference. That's providing something. Now, in accordance, in alignment with that, we have someone from St. Luke's who is there to answer any medical questions as well. So that's something that we're doing to disrupt a system in 1 second and chew. So it doesn't take a big operation like that to make a difference. It's just coming up with an idea and finding people who are in alignment with that same idea and tackling one issue at a time. Because in the grand scheme of things, if we all attack one specific issue and they're all different issues that are near and dear to us, then we're making a change in some capacity. So I feel like we take so much on to, oh, I want to change the world, but it seems too big to do one thing, to do anything, so people just shy away from it. It's enough to start somewhere and find one thing. Why don't you just pick up some trash in your community, you know, make community bracelets, art, you know, something that you are in touch with yourself, something that brings you joy that you want to share with your community in a positive way. So,
and Mishawn, I have great respect for people who do all those things. Try to do some of it myself, probably not enough, but if we don't, I mean, I think the conversations like this are about challenging folks to think in bigger terms, and you know, if we could attack poverty in a substantive way, so that families didn't have to go get food but had enough resources of their own to pay for their own food, that's the systemic policy change.
Yeah. And I think for me, it's like there is a space for charity, but then there's a space where we gotta become not as reliant. Because the thing is this, in my mind, this is just my opinion. And I appreciate your opinion so much, Mark, because it's getting me to think. It's making me think. So I appreciate, because this conversation is necessary for all of us. All right, when it comes to policy changes, in my opinion personally, I feel that so my mother, she grew up she was born in 1945, and I spoke to her this morning about what I'll be doing today here, and what she told me was this. She said things aren't as bad as they used to be in regards to just having some sort of equality, but we still have a long ways to go. And there's two different worlds, you know. There's a world where people are privileged, and there's a world where people are not. And when it comes to policies, that takes a long time to change things. And in my mind, in my world, I don't feel that has to be done on in the same spectrum. So if there's a group of people who want to tackle or feel a need to tackle the policy specifically, then that's a group that goes to do that. But on a community level, I think we have to start reclaiming our communities and making them more healthy, because that's all I have control over. I mean, I can speak up about policies, and of course I will do that. But what can I personally do to make a difference that can influence something now, instead of waiting for someone else to do something for me? So that's kind of like just my view on it.
Right. Thank you so much, Mishawn, for addressing that. Thank you, Mark, for raising that question. We do have another question. I do want to make sure that in response to that, that was a really healthy dialogue and information on both sides. And I think what we're seeing here is that there's not just one solution that's going to come out of this webinar or out of this webinar series, right? So we don't want to set the expectation that you're going to attend this webinar and now we fixed it and there are no more health inequalities, and now here's a bill, we wrote it up and passed it. So that's not,
but it's not going to happen right now.
Right, that's not the expectations. There are going to be many different voices here. What we want to do is is raise our voices. We want to have the conversation. We want to stay aware. And so we're going to move on to the next question. Charlene has a question that she wants to ask. So Charlene, you can unmute yourself and ask your question now.
So mine's not more of a question, it's more of kind of like a statement. I know we were speaking about how we wanted to voice the fact that some of us do have privilege. And I wanted to say that, you know, I am Dominican and I was adopted by 2 white parents. I was raised and went to a Catholic school all throughout my entire education. I've been very lucky to be blessed with that opportunity to be accessible to, you know, a great education. And I know I was talking to, I work in the pharmacy, I work in the hospital, I work 2 jobs in the hospital. And I was talking to the pharmacist that I work with, and I was telling her about how, like, it's kind of hard for me to think of the times that I'd been prejudiced against, because I really hadn't been. And then she made me like think deeper and like think about like the things. And I remembered that when I was younger, I was probably in, you know, 3rd grade, and I've always been at a much higher reading level than what I should have been for whatever that age was. And she told me that I was not allowed to check out some books that I was wanting to read. And I was not allowed to, but one of my peers, Amanda, who is Caucasian, she was allowed to take out the very book that I had wanted to take out. And my mother, I had to go home and I was telling my mother about it. The librarian still, after my mother had spoke with her, would not let me take out the book that Amanda had taken out, because she didn't think that I was at that reading level that I could have been. And I just think that that's like really interesting to see, because it's like Mishawn was talking about with the 2 rooms, with thinking about like the clutter of the one versus the piece of the other. Like when you're so used to like small things like that happening, you almost don't see them happen. So I think that that's like a really interesting thing to like think back on from when I was so young, and like realize that that had happened, and didn't even realize that it was probably something having to do with my color.
Thank you so much for sharing that, Charlene. I don't know if Dr. Alang or Mishawn, do you want to say anything in response to that?
Just appreciation, just a lot of appreciation for sharing that, because these stories are really important as well.
Mm-hmm. Yes, absolutely.
I really appreciate this discussion. It's beautiful, I feel.
Agreed. So we've got about 9 minutes left. I don't know if anybody else has anything that they want to share. I'm going to send out a poll right now. So I'm going to launch the poll. You guys should now be able to see the questions. Again, I just want to echo everything that's been said. We just really wanted to lift up community voices here. Everything that's been said is really powerful and important. We all have such different backgrounds and things in our backpack that we bring to the discussion, and things that influence how we look at the world around us, things that influence how we perceive the social determinants of health and how we're impacted by them. So it's really nice to be able to come together and have this conversation and learn more about each other, learn more about the topic, but also learn more about ourselves. Just as Charlene shared how, you know, thinking about these things has caused her to look deeper into her own experience. And so I'm hoping that we're all able to continue to do that as well. I'm also gonna give way for Julie right now so that she can just announce next week's topic and make any final remarks that she may want to make.
Okay, I just want to thank Ola and Mishawn and Dr. Alang for just sharing their incredible experience, all this information, and making these social determinants become tangible and real for all of us, or at least certainly for me. It was really, really interesting for me. And I just want to share next week's topic is addiction, recovery, and substance abuse. And the presenters will be Yamalisa Taveras, who's the project director at Counseling Solutions of the Lehigh Valley, and works at Lehigh Valley Health Network, and Jose Rivera, who is a community member and shares some of his real life in real time experiences. So I look forward to seeing you all next week, and I hope you really got a lot out of this incredible webinar. Thank you.
Yes, absolutely. Dr. Bass, are you on? Do you have any final remarks that you'd like to share? You might not be on anymore. Okay. All right. Dr. Alang, Mishawn, is there anything that you...
I just want to thank everyone for coming, and 2 hours can be a lot, but when we start talking about these things, they can, it's just one of those things that we need to constantly talk about, and it takes time. But I really appreciate everyone coming and really appreciate everyone's voice, and let's just keep working. We like you said, Mishawn, we are not going to leave here and have figured out the answers. And like I said earlier, we don't have all the answers, but just keeping these conversations going is really important. So I really appreciate everyone for taking the time even to be here. I appreciate it.
And I definitely want to add to saying thank you for this experience. It's been something that, it's going to be on my mind for a while in regards to seeing in what ways can I really, influence and help a community in like a different way. So this was definitely something that has inspired me, to make more of a difference in whatever way I can. So I appreciate all of you for being here and giving me the space to share with you.
All right. Well, thank you guys, and we hope to see you next week.
Thank you.
Bye.
Bye.